Delighted. The stars aligned and allowed me to come here, so thank you for asking me. My name's Gerhardt Attard. I'm a clinician scientist in London and the director of UCL Cancer Institute. I'm a medical oncologist. I treat patients with advanced prostate cancer, which I define as patients who, if not managed, the disease will be potentially lethal. I understand today there's a mixed audience of physicians, urologists, oncologists, people involved in public health policy, patients. I'll try and, I guess, speak to all of you and really cover the latest data in this field. And suffice to say, this is rapidly changing. At the ESMO annual meeting in Berlin a few weeks ago, we had 7 or 8 abstracts of new data, presentations of new data, which is changing the management of patients in this category. I've not updated my slides to include all that data. It hasn't all been published. So I've stuck to, I guess, the state-of-the-art understanding of the field up to ESMO. And over the next 9-12 months, as the new data settles in, we'll update our thinking. But there are some important concepts that will not change, that I will emphasize today. These are my declarations of interest. Probably most importantly is that I run a translational lab. As the introduction said, I work on a large trial called the Stampede trial. This was started in the UK in 2005, has randomized more than 12,000 patients with, as I said, advanced prostate cancer. We have partnered with a number of pharma companies to test drugs, which at the time were new drugs. They're now standard of care. And more recently, we've partnered with biomarker companies to test tumor tissue from our patients and implement tests, which I think will change management, as I'll discuss today. I'll start with my conclusions. So this population of patients, advanced patients, should receive hormone therapy. I'm not going to get into the debate about who we should treat, who we shouldn't. The population I'm speaking about should all receive treatment. And they all should receive treatment with androgen deprivation therapy and an androgen receptor pathway inhibitor. We have a number now. We have the steroid synthesis inhibitor abiraterone, and we have at least 3 potent androgen receptor antagonists, enzalutamide, apalutamide, and darolutamide. So that should be the backbone for every patient who presents with metastatic disease, so spread, visible on a CT or a bone scan. Whether we should include PSMA PET on that, in that group, we can discuss if we have time in the questions. We then have a very high-risk population. The majority of PSMA PET positive but conventional imaging negative patients fit in that high group. But because we started our trials 10, 15 years ago when PSMA PET was not available, we still have to define that group based on those clinical factors. So those 2 sets of patients, it's ADT and an RP. Second point, if there's a BRCA mutation or loss of BRCA, and we should be testing for this as a reflex test when a patient is diagnosed with prostate cancer, should receive a PARP inhibitor. And we'll probably debate whether we should start it up front or whether we should start it at relapse on the RP. But a PARP inhibitor must be used over the course of their treatment. I'm going to talk about molecular tests for making that treatment decision. I'll briefly talk about the clinical implications of some of the biological findings we've made. And as I said at ESMO a couple of weeks ago, we had so much data which is going to further change the field. So I'll start with this non-metastatic group. And this is a bit of a misnomer because we do not see metastasis on a CT or bone scan, but based on clinical features, feel there's a very high risk of that patient having spread. And as I said, now with the use of PSMA PET and more sensitive imaging, we are identifying an area of spread for the majority of these patients. Now, the Stampede trial, when the trial was started in 2005, the hypothesis was that this group will behave in the same way as patients who have more extensive disease. And probably they do for a lot of different treatments. But what became clear over the next decade was the outcomes were very different. So the proportion of patients who had an event, either died or their cancer had relapsed after 10 years was different. So when we first reported the data for the whole group together, the trial efficacy result was driven by the metastatic patients. So we took the decision to split them and subsequently report the two groups separately. So those of you who've been following the data merging from Stampede, that's sort of an important footnote that you'll have picked up over the time. Now, this high-risk group are defined as either having lymph nodes, so node positive in the pelvis, or if node negative, having at least two of the high risk or clinical features you see there, PSA 40 or over, T3 or greater, Gleason score 8 or greater. It is critical that you only interpret these findings in the context of those clinical features. They are much higher risk than NCCN high risk. And we've been saying this for a year, 5-6 years since we first presented this data, and it really came to the fore at ESMO, because a similar trial in that we randomized patients to ADT and radiotherapy and an ARPI, in that case enzalutamide, was tested in a wider group, so included all NCCN high risk. And for those of you who have seen the results, there is no benefit for metastasis-free survival or survival when we treat all that group. So what we learned at ESMO is for this group of patients, or what we learned 5 years ago, for this group of patients, there's clear benefit. If you go too far to the left, i.e. where an increasing proportion of patients will die from another cause or will not relapse, importantly, then you do not get any benefit from adding an RP to ADT. But for this population, we clearly should add abiraterone. As you can see here, there is a clear and consistent benefit. 6-year overall survival was improved or is improved from 77 to 88%. When you look at secondary outcome measures, prostate cancer specific survival, that is improved from 85% to 93%. There's two messages here. We need to identify the remainder of patients who are relapsing and intensify their treatment, but we cannot run trials or offer treatments to all patients because the chance of detecting a signal when the rate of death from prostate cancer is 7-8% is low. And importantly, there'll be a high risk of overtreatment. Now, I've already mentioned ENZA-RAD. I don't have slides from ENZA-RAD. It hasn't yet been published, but I've said that in the ENZA-RAD trial, which was primarily node-negative patients, there was no evidence of a benefit for adding enzalutamide to ADT. In our trial, we used abiraterone. We also had a similar trial, abiraterone and enzalutamide. My conviction, I think everyone will agree, it's not the RP, it's the population of patients in those two trials. You can see here in the node positive, the hazard ratio for metastasis-free survival, which really tracks overall survival very closely, was 0.49. So greater than 50% reduction in the risk of metastasis or death. For node negative, when you select those very high risk features, the risk or the hazard ratio is 0.6. As you start to include more patients, that starts to slip. Now, what can we do about this? A number of approaches can be used. There's one I'm going to speak about specifically, which is using digital pathology slides. And there's a number of companies that have, I guess, both the AI expertise and the computational power to test thousands of slides. And we have collaborated with a company called Artera, which also collaborated with a number of large US consortia trials. So they had access to or used more than 20 slides from more than 20,000 patients. They or together with them, we included clinical data, so age, PSA, T-stage, not Gleason. We actually don't need Gleason any longer in that algorithm. And then the digital images of the H&E. And what we're able to do in the Stampede population is they identify a very high risk within that high risk group, which is shown on the right, and a lower risk group of patients. And you can see in the lower risk group, the benefit from adding abiraterone to ADT and radiotherapy is not evident. Now, this was a training set, this was a discovery cohort, but we will test this type of approach in the ENZA-RAD trial, and there's a couple of other trials that this can be validated in. So the way I see this evolving in the future is that the decision on who to treat with ADT and NRP will be based on a model which is either this one or a similar one which has been equally validated, but will extract additional information from that H&E slide. How will we use PSMA PET? I'm not sure. Probably there's going to be a lot of overlap, and that is the sort of data we need to generate. We do not currently have enough long-term follow-up from patients where PSMA PET was done at diagnosis to understand its prognostic utility. As I say, I think there's going to be overlap. So questions that remain: can we extrapolate the data I showed you with abiraterone to AR antagonists? I've said my conviction is yes. We've really had a cat thrown amongst the pigeons with the ENZA-RAD trial where we do not see that benefit. As I said, I don't think that's enzalutamide. I think that's a population of patients. Can lower-risk patients gain the same benefit? We're going to need tests to identify them. Yes, and I've talked about the ENZA-RAD trial. There's another population. These are all synchronous patients. There's another population which is relapsing patients. So PSA is rising after primary treatment. By definition, these are higher risk than someone who's presented de novo because they've already gone through that stage. Within that group, there's a much higher chance of relapse and death from prostate cancer. So the EMBARK trial, which was published in NEJM a few weeks ago, concurrently with the ESMO presentation, showed a clear benefit for survival for that relapsing group. But again, in the control patients, the event rates are in the order of 20 to 30%. So there is still over-treatment, but clear benefit when we treat all patients. I'm often asked about surgery. Should we extrapolate this to surgery? Philosophically, biologically, I see no reason why not, but those trials are ongoing. Finally, what is the ideal treatment duration? So for this population, we gave 3 years of ADT, so that's LHRHA, and 2 years of NRP. We chose that somewhat, well, it was an informed guess. Shorter may be as effective, or longer may be more effective. We don't know. And I think it's going to be really hard to show that. That's going to require really large trials, which will run for a long time. So we're probably stuck with 2 years. What I do in practice, as long as a patient is tolerating treatment, I go to 2 years. If I see side effects, I then make that balance. And that really requires a patient-centric decision. Now, moving on to metastatic. So if you see mets on a scan, the next question is, are they high volume or low volume? And that's an important distinguisher because the number of mets you count on a CT or bone scan is prognostic. If they're low volume, we also know that if we irradiate the primary, then that improves survival. So the management starts to differ based on whether a patient is low or high volume. But I'll draw your attention to something that's really driven my science, which is the high proportion of patients on an ADT-RP who are in remission after 10, 12 years. So this was the updated follow-up after 14 years survival that we published recently. And 30% of patients continue ADT and NRP, including in the high-volume group. So the conversation I have with my patients when I start treatment is very different from 15 years ago. And it's really starting to discuss concepts about risk of over-treatment, but not wanting to miss the opportunity to prevent that early progression. And I'll finish off my talk with that. I'm often asked about which RP. I'll just summarize. The efficacy is the same. The decision over which drug to combine with ADT is driven by drug-drug interactions and different safety profiles. I mentioned radiotherapy. There is debate on this. We have a few trials, and as often happens in the field, not every trial gives the same result. This is an individual patient data meta-analysis, which has used data from 3 trials. The Stampede trial is by far the largest. You can see the numbers, nearly 2,000 of patients. And in that trial, we saw a clear signal of a survival benefit for low-volume patients who received radiotherapy. Similarly in HORAD, which was a smaller trial, but within the PEACE trial, which was a European trial, there's a bit less certainty. Overall, we are, at least our interpretation of the data is that radiotherapy should still be used for this population. So I've already alluded to this. We have an increasing group of patients who present with metastatic disease, especially who have low volume, who will not die from their prostate cancer. But we also want to treat this group who rapidly progress, and that constitutes about 30%. So move on to treatment intensification. What can we do in addition to ADT and NRP? So docetaxel. So we've been using docetaxel for nearly a decade now for this group. There are trials that have tested ADT, docetaxel, plus or minus NRP, and here's the results. Adding NRP improves outcome. What we do not have is level 1 evidence for adding docetaxel to ADT and NRP. These trials are starting, but it's challenging now to randomize a patient, a physician, and the patient feels fit in a very poor prognostic category to potentially not having that triplet therapy. But there's an issue or a consideration with docetaxel. The effect is heterogeneous. So clinically, we clearly identify heterogeneity, so not all patients derive the same benefit. And it seems like the synchronous metastatic patients with the bulky primary tumors are the ones who derive the greatest benefit. So this is an individual patient data meta-analysis. So heterogeneous effect and an impact on quality of life. This is data from Stampede, where the black line are patients who received ADT alone, the red line, ADT and abiraterone, the blue line, ADT and docetaxel, and these are patient-reported outcomes. As you'd expect, there's a drop in quality of life at 6 months, but it doesn't return to the same level as patients on ADT and RP, so there's a long-term impact on quality of life. If we're prolonging that patient's life, that might be acceptable, but if we're not going to make a difference because the patient's likely to be in remission after 9 years, that's probably much less acceptable. So we need our prognostic tests to identify who's going to relapse, and then we need predictive tests to work out whether the cancer is sensitive to docetaxel or not. One approach that's being tried is follow PSA. And if PSA doesn't drop, then you add in docetaxel. But there's a number of potential issues with that. So I'll move on to an experiment we recently published from the Stampede trial dataset, where we collected tumor samples from about 2,000 patients. We performed expression array analysis on those. We used the single gene values to derive 59 signatures. We predefined 4 signatures for testing for prediction, based on a training experiment we did in another trial called Charted. So this was a test. This was a validation of the Charted data. And what we found was the Decipher signature. I won't go into too much detail on this. This includes 22 gene regions and is used to decide whether a localized patient should be treated aggressively or less so. In metastatic disease, the Decipher signature predicts whether a patient is going to benefit from docetaxel or not. So you're seeing a high Decipher versus a low Decipher. Now, this is a different cutoff from used in localized disease. This is not level 1A evidence, it's level 1B, because the question was asked before the molecular data was linked to the clinical outcome, but not before randomization started. As I said, randomization is probably going to be difficult. We're trying to initiate trials in that setting, but that's going to be 5-8 years till those report at best. So currently I use this information when there's equipoise, when I'm unsure whether a patient should receive docetaxel and the patient's uncertain. That's where potentially a molecular test could be used. Now that effect is consistent whether the patient has low volume disease or high volume disease. As I said earlier, volume is prognostic, but you will see on the left side, the high decipher always derive benefit. I'm mindful about time. I'm going to skip this part because it's more exploratory, and I'm just going to talk about BRCA because this is important. So we know that patients who present with advanced disease, who have a BRCA alteration, have worse outcomes. You can see this here. So these are metastatic HSPC. Red line is BRCA, black line is non-BRCA. That's in a population receiving a range of treatments, ADT docetaxel, ADT abiraterone. So I've worked with Janssen to test the question of whether a PARP inhibitor combined with ADT abiraterone will improve survival. So it's a large global trial, over 6,000 patients screened with molecular tests of their tumor, and patients who had a BRCA alteration or an alteration in a list of other genes shown there were randomized in a placebo-controlled design, and the primary endpoint was radiographic progression-free survival, which you can see here. So the trial met its primary endpoint, giving a PARP inhibitor to a BRCA loss or mutant patient reduces the risk of radiographic progression or death by 48%. So that's a headline result. Has a significant impact on symptomatic progression-free survival. So this is a patient-centric output, 56% reduction in the BRCA group. And now, of course, the next question is, when should we use a PARP inhibitor? At start, as shown here, or later? And ultimately, overall survival readouts will give some indication of that. This is the overall survival output at this first interim analysis, where there are half the number of deaths that will be required for a final statistically powered analysis, which will happen in the next couple of years. But I think the trend is looking encouraging from the trial point of view, where the patients with a BRCA alteration or randomized to niraparib have an estimate of a 25% reduction in the risk of death. And I think this is important because I've said a BRCA mutant patient should receive a PARP inhibitor. We can either use it for line 1 mCRPC, which is when an RP stops working, and that's what's shown here. So if a patient with a BRCA mutation is randomized to either receive, so actually this is line 1 mCRPC who haven't received an RP, but it really is convincingly showing that if we add a PARP inhibitor for mCRPC, and you can see overall survival above, the PARP inhibitor used here is talazoparib, the improvement in survival is, the hazard ratio is 0.5, so very significant improvement in survival. And here is a not insignificant proportion of patients who are in the placebo group received a PARP inhibitor subsequently. I've shown you survival analysis with less follow-up when PARP inhibitors are used earlier on. So I'll finish off with a summary. When a patient with and focusing on metastatic disease, which is where there's a much more debate about treatment intensification. So if a patient has low volume metastatic disease, they should receive radiotherapy to the primary. We should consider docetaxel, especially for patients found to be decipher high on molecular testing if there's equipoise. We should use RP to progression. We should test for BRCA mutations. And if a patient has BRCA loss, a PARP inhibitor should be implemented at some point in the treatment pathway. I find the data from Amplitude pretty compelling to start niraparib at the start, but that will continue to be debated, and the regulators will need to make decisions on that, on extending the license and subsequently the funders. We're currently using ADT lifelong, but there are trials starting about de-escalation, so stopping treatment, giving a break. And I said at ESMO there were at least 2 positive trials. The first was for lutetium PSMA, which many of you will know about, which is currently used in mCRPC, which showed a delayed progression. And capivasertib, which is an AKT inhibitor, which was tested in patients with PTEN loss on immunohistochemistry. Both trials are immature. We're going to need, that's the bottom line, encouraging, positive signals, but currently immature. So they're not going to change our practice anytime soon, but watch this space. These are my conclusions, which I started with, so I won't repeat them, and just take time for questions. Thank you.